This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse.
Welcome back to Audible Bleeding. Today we have our second and hopefully many collaborative VSITE review series. Today we're going to talk about thoracic outlet syndrome, and our content today has been provided by Dr. Nadal Khatib, who's a senior vascular fellow at the Prince of Wales Hospital in Sydney, Australia. Welcome to Audible Bleeding, Nadal. Thanks for joining us.
Thanks for having me, Matt.
All right, let's go ahead and dive right in. What exactly is thoracic outlet syndrome, and what are some of the demographics?
Well, thoracic outlet syndrome, the best way to describe it is a constellation of signs and symptoms relating to the compression of the neurovascular structures that occurs as these structures travel between the thoracic aperture and the upper limb. And just in terms of the different types of thoracic outlet syndrome, there's venous, arterial, and neurogenic, which are the largely described types of TOS. And by and large, the most common type of TOS would be neurogenic, which accounts for reported over 95% of cases. The second most common is venous TOS, which accounts for about 2 to 3%. And the most, the rarest is 1%, is arterial TOS.
Yeah, perfect. And so just to clarify for our listeners, when you say TOS, you mean thoracic outlet syndrome, obviously. What about some of the anatomy of the thoracic outlet? Can you walk us through some of that?
Yeah, so the anatomy is actually quite important to understand, and it's the best way to fully understand this area. And there are particular areas in the thoracic outlet which you really need to appreciate thoroughly. So these three spaces or three areas in this anatomical region are the interscalene triangle, the costoclavicular passage, and the Sub Coracoid Space. Is really based on the attachments of the anterior and middle scalene muscles on the first rib. And the diagnosis of these various types of TOS is really what determines the ultimate surgical management of the compression involved. So I'll just quickly go through the attachments of these two muscles just to outline this space. The anterior scalene muscle has attachments to the cervical vertebrae, 3 to 6, and the scalene tubercle on the upper surface of the first rib. The middle scalene muscle is a little bit different. It's more posterior, and it's attached to the posterior tubercles in the intertubercular lamellae of the cervical vertebrae and the quadrangular area, which is a area on the first rib a little bit further posteriorly from the scalene tubercle. And it inserts onto that groove on the first rib. The first rib is another area that you really need to appreciate to fully identify this area. The first rib is usually described as the broadest, the flattest of the ribs, and it's described as an atypical rib. So the reason why the first rib is called an atypical rib is because it's not attached to vertebrae, only the single vertebrae that it's attached to. The upper surface of the first rib has two important landmarks, which we've already mentioned, the scalene tubercle and the quadrangular tubercle, for the attachments of anterior and middle scalene, respectively. There are also three grooves for the subclavian vein, the artery, and the lower trunk of the brachial plexus. And the inferior surface is a smooth, and inferiorly there's a medial attachment for the suprapleural membrane, or Simpson's fascia, which is also referred to in some texts as the scalenus minimus muscle, which is tethered to the C7 vertebrae.
Great. Tell me about the costoclavicular passage.
This is a passage of the subclavian vein, which largely emerges through the tight space created by the clavicle, the subclavius muscle, and the costoclavicular ligament. And also more posteriorly, this can also compress the artery and nerves, as this space can also be narrow in relation to the scapula and the subscapularis. The subclavius muscle is important to appreciate as well. It's attached to the costochondral junction of the first rib and is inserted into the subclavian groove on the inferior surface of the clavicle.
Perfect. And finally, what about the subcoracoid space?
This space is best appreciated by the intimate knowledge of three things. One, the coracoid process and its attachments. Two, the pectoralis minor muscle. And three, the clavipectoral fascia. So I'll just start with the first one, the coracoid process. This arises from the scapula as a quote-unquote process with a broad-based bony landmark, which offers attachments to muscles and ligaments. The relevant attachments here are pectoralis minor, occupying the medial border for about 2 centimeters behind the tip. The tip itself is fully attached by a medial lateral facet, which gives space for the short heads of biceps and the coracoid brachialis muscle, respectively. The pectoralis minor muscle is attached to the bone of the 3rd, 4th, and 5th ribs and the medial border of the coracoid process, as mentioned. And then finally, clavipectoral fascia is a sheet of fascial membrane that fills the space between the clavicle and pectoralis minor, splitting and encompassing the subclavius muscle. Its superior portion is what can be thickened in this area and can become a tight band referred to as the costocoracoid ligament.
Yeah, that's right. And this anatomy is especially important to think about when you're considering doing a pec minor release. What about nerve anatomy? Let's skip over to that, since those are some of the things we're all afraid of in doing this operation. Are there any anomalies in this anatomy?
So particularly with the venous compression, the one to be most aware of is the phrenic nerve. And the phrenic nerve anomaly that can occur is where it usually runs anterior to the subclavian vein. It can also run very close to the anterior border and compress the vein itself. And in very rare circumstances, due to the timing of development, can run through the vein as well. And this can cause compression and scarring of the vein and can cause the compression of the vein, which can become a clinical problem as well. The anomalous anatomy, also to mention, that can also cause TOS, especially when patients have a cervical rib or anomalous first ribs or a congenital band, is also important. And the incidence of anomalous first ribs and cervical ribs is quite low, 0.76 and 0.75% respectively. However, the incidence of bands are actually quite high, as high as 63% in some reported literature in the general population. It was largely based on cadaveric exploration and imaging as well.
Can we talk about how the anatomy relates to the different types of thoracic outlet syndrome?
Yeah, so when it comes to the different types, there's obviously different areas of the anatomy that we've described that can cause compression. So when it comes to neurogenic thoracic outlet syndrome, the most likely area to have compression of the brachial plexus is the scalene triangle. And this can cause, as I mentioned, brachial plexus and neurogenic TOS. The other areas is slightly above the first rib, where there's a cervical rib or fibrous bands that can compress the nerves. That can be quite common, and also anomalous first ribs. When you look at arterial TOS, the most common causes is cervical ribs and anomalous first ribs, but you can also have compression in that scalene triangle as well. And then lastly, venous TOS is usually more common with costoclavicular passage anatomy compression or sub coracoid space, and which is why in those instances, pec minor releases can be quite important.
All right, so now that we're experts in the anatomy of thoracic outlet syndrome, let's dive into the patient. What are the clinical exam findings of thoracic outlet syndrome?
So with your patient history, which is the most important thing to help identify the causes of symptoms, you need to really take a thorough history, interrogate the symptoms and signs very closely. The most important thing is to exclude any history of trauma. A lot of patients may have a history of trauma, a clavicle fracture or clavicle malunion, and that can cause a lot of scarring and compression and might not all be related to the first rib. If there's any associated symptoms like headache, visual disturbances, neurology in the upper limb, it's important to document that very clearly preoperatively and also to help guide the diagnosis. There's important syndromes to be aware of, which can sometimes shadow or mirror the symptoms of thoracic outlet syndrome, particularly neurogenic. It's always important to exclude things like carpal tunnel and antecubital tunnel syndromes if the symptoms are isolated to the arm or the forearm. Patients with venous TOS may present acutely, and we've all seen this in our clinical practice, where patients who are usually young come in with an acute swelling of one upper limb and have an acute or subacute upper limb DVT. And patients with arterial TOS are a little bit more rare, but can also have upper limb ischemia. And it's important to investigate other causes of ischemia in these patients. But I think overall, what you'd notice is that these patients are a very different demographic to what we're usually used to. These are usually younger patients usually in the late teens or early 20s when they start developing symptoms.
Yeah, and just to add to that, we usually often think about some type of history of excessive use of the arms, especially above the shoulder level, athletes, violin players, construction workers, something like that, where they might really hypertrophy those muscles to exacerbate any slight anatomic abnormalities. What about on physical exam findings? What should we look for there?
Yeah, so there are provocative maneuvers that are largely used for neurogenic Pos. While these are described and mentioned in most texts, their utility largely is beyond the scope of vascular surgeons in terms of the assessment and diagnosis of neurogenic Pos, but it's still good to go through them. A lot of these tests are done by physiotherapists with routine experience in performing them. But the most common one is Addison's test. The best way to describe this is have the arm extended, abducted, and externally rotated, and you palpate for the radial pulse. That's the first step. The second step is you rotate and laterally flex the neck to the ipsilateral side while inhaling deeply, and then a positive test results in reduction or complete obliteration of the radial pulse. That's Addison's test. And that can be quite useful for arterial Pos or neurogenic Pos. Obviously, with patients who present quite late, this isn't possible, but it can give you an idea if there is arterial compression in the thoracic aperture. The second test is Roost Test, which is also referred to as East Test. And this is best described by the patient being seated or being sitting down, and both arms are abducted to 90 degrees and externally rotated, and the elbows are flexed at 90 degrees. And then you ask the patient to open and close both hands for 3 minutes or until pain or paresthesia sets in. And this is quite a long test that can be performed, but this will give you a good idea if there's significant neurogenic or nerve compression in that area that results from overhead use with the upper limbs. And then the last one is Alvey's test to mention. This is where the patient has both arms abducted to 90 degrees with the elbows extended and dorsiflexed both wrists. And if pain is elicited as the wrists are dorsiflexed, then the test is positive. A further maneuver is then performed laterally. Flex the head on each side. And if pain is elicited on the contralateral side to which the head is flexed, then this is also a positive test. So there's two ways to sort of elicit pain in the Alvey's test. And again, this is largely for neurogenic Pos as well.
And now on top of obviously a thorough history and physical, some of these provocative movers, what other workup of patients with TOS should we think about?
Yeah, so whilst largely the clinical and history examination will guide you to the most likely cause, there's still important studies to perform to not only to have a baseline, but to exclude other pathology. So always start off with the non-invasive vascular lab tests. A digital brachial index is a good way to start, and this can be done bilaterally, and you can use those to compare like with like or left with right. And arterial duplex is also important, particularly with arterial Pos. These patients can have subclavian artery aneurysms, which can have a lot of mural thrombus, and also cause distal embolization. So an arterial duplex is important to look at the overall integrity of the arterial supply to the hand. And then, of course, a venous duplex, particularly with those patients who you're worried about venous Pos in the acute setting, exclude upper limb DVT with a venous duplex. And you should be able to see quite a lot of the anatomy. As we said earlier, these patients are usually younger and have sort of lean anatomy to allow for good thorough ultrasound examination. The other radiological modalities which you'd probably be seeing with these patients is a CT venogram. And this is commonly performed in the acute upper limb DVT or suspicion of VTOS setting. A CT angiogram can be used for the evaluation of arterial Pos or excluding other causes of embolization. Particularly if you're concerned about distal embolization, it's good to exclude other sources of embolism, such as a thoracic aneurysm or proximal source throwing off emboli. And an MRI can be performed if you have ongoing concern about compression and haven't fully identified the anatomy, or if you're concerned about related neurovascular compression. There are some nerve conduction studies that can also be performed, and electromyography as well. for neurogenic Pos. And this is largely done after consulting with a neurologist and going through a thorough physiotherapy exam and excluding other causes of neurology in the upper limb.
Yeah, that's great. I would just add that some people advocate for an operative venogram with provocative movers just to see how that changes collateral filling throughout the shoulder with the arm extended and abducted. And then also, I don't know how much you're doing these there, but at least at one institution I've been working at, we've been doing scalene blocks for concern for neurogenic thoracic outlet syndrome, on the idea that if you can paralyze the scalene muscle and relieve the symptoms, that the patient would likely do better without said scalene muscle.
Absolutely, yeah. It's a good sort of diagnostic test as well to see if they have a good response to the surgery. Yeah.
What about Paget-Schrödinger syndrome? How does this relate to thoracic outlet syndrome?
Yeah, so we hear the term Paget-Schröder thrown around a lot, and it's usually synonymous with venous Tos. So just a bit of history. It was first defined by Hughes in 1949 in reference to two people who described it. The first guy was Sir James Paget, who in 100 years earlier defined acute arm swelling and pain as possibly related to what he thought was vasospasm. And then about 50 years later, von Schroeder came along in 1884 and attributed that described syndrome of upper limb swelling to the presentation of a subclavian or axillary vein thrombosis. And then Hughes coined the term Paget-Schröder syndrome, and that's where we get that name. So as I said, it's usually now used synonymously with venous thoracic outlet syndrome. Paget-Schröder syndrome accounts for roughly 10 to 20% of all upper extremity deep vein thrombosis, which is quite high when you think about overall the number of DVTs in the upper limb. So it's usually something that's described as synonymous with venous Tos.
So now we've done our history and physical and gotten a full workup, and we've decided that our patient has thoracic outlet syndrome. Talk to me about some of the surgical approaches for a first rib resection.
The three main approaches have largely been divided into transaxillary, supraclavicular, and infraclavicular. And each approach allows you to take out the first rib, or at least a significant portion of the first rib. Each type has sort of a specific benefit to the different type of thoracic outlet syndrome. So I'll just start with transaxillary, and I'll run through the advantages and disadvantages, and then I'll run through the same for each other type. The first one, transaxillary, the advantages is that usually it's a lot more cosmetically appealing. The reason being is that the incision is actually in the axilla along the hairline, which allows it to sort of be hidden and not really revealed during exposure. So some patients would prefer a transaxillary approach from the cosmetic reason. The transaxillary approach also allows you to take out a significant amount of the first rib anteriorly and posteriorly. The disadvantages, however, is that it can be quite difficult to visualize the anatomy which is dependent largely on good assistance. So you really do need to have the arm elevated with someone who's willing to be able to hold it up for a decent amount of time. There is a lot of maneuverability that's allowed and necessary to expose this area. And the other disadvantage is that there is risk of T1 nerve root injury, subclavian vein injury, and arterial injury when doing this procedure if it's not done properly. And then if that does happen, there is very limited exposure available to repair these injuries. It's not a good approach for cervical ribs or scalene triangle or patching the subclavian vein, obviously. And if you do have arterial Tos, which requires revascularization, then obviously, at least in the same setting, it's not the best approach. But advocates for the transaxillary approach would say that, you do get a good view of the relevant anatomy and can take out a decent amount of the first rib. The supraclavicular approach, this is good for scalene triangle access and debulking and cervical rib resection. It's required for arterial Tos if arterial reconstruction is necessary. However, the disadvantages of the supraclavicular is you're unable to fully expose and decompress the venous compression or visualize the full vein adequately. And obviously, it's cosmetically less appealing given the location. The infraclavicular approach, which is the last one we'll mention, the advantages is that it gives you good access to the vein for venous decompression. It also allows for necessary venous patching if you need to patch it. And it also allows for the excision of the subclavius muscle and the costoclavicular ligament. And as we mentioned earlier, if you are doing a pec minor release or a pec minor detachment, then this is also a good approach to have the two done at the same time. Its disadvantages, well, you're unable to expose the subclavian artery fully. So for arterial TOS or neurogenic TOS, this isn't particularly the best approach. It's difficult to access the most posterior aspect of the rib, and it's cosmetically less appealing. And obviously, with this infraclavicular approach, you're not going to be able to remove any cervical rib or bands or scalene bands.
Great. That's a really good review. So let's go ahead and step back into some of these specific different types of TOS and go through them in a little more granular detail, starting with venous TOS.
Venous thoracic outlet syndrome has an incidence which is quite low. About 2 out of 100,000 people develop VTOS. The demographics, as we mentioned earlier, these are younger patients between in their late teen years of 18 years to about 30 years. It's been reported more commonly in males than females. And usually the way in which these patients present is with upper limb edema, upper limb pain, and cyanosis. The edema affects the shoulder, the arm, and the hand, and characteristically is referred to as non-pitting edema. There's usually a lot of collateral vein dilatation over the shoulder, over the neck, and over the anterior chest wall to accommodate for this increased venous hypertension that they develop. And there's usually pain on exertion of the upper limb, described as usually stabbing, aching, or tightness. And going along with upper limb DVT, the reported incidence of pulmonary embolism, which is important to exclude, is less than 12%.
What are the relevant aspects of a history do we need to specifically hone in on for VTOS?
An important differential to have in the back of your mind for upper limb DVT in general is obviously venous thoracic outlet syndrome, which we're talking about, but then also congenital phrenic nerve anomaly, as we mentioned earlier. A history of fracture, clavicular fracture, and malunion can be quite common in this area. And always remember that these patients may have repetitive arm provocative maneuvers and occupations or exercise habits that result in an repetitive overuse of the arm and overhead arm use, particularly in patients who have spent a lot of time in the gym and are into bodybuilding. They can develop quite significant hypertrophy of pectoralis minor, and that area becomes quite narrow and compressed. And it's important to have a high suspicion of VTOS in those patients. Exclude a pulmonary embolism, obviously, and that should be done very urgently as well when you've seen the patient. And obviously, you want to exclude any venous gangrene or phlegmasia of the upper limb, which fortunately has a very, very low risk in these patients, but always important to exclude phlegmasia of the upper limb.
Once we find this, what are the goals of therapy with treating venous thoracic outlet syndrome?
The goals of therapy largely is to prevent any immediate risk to the patient, whether it's venous phlegmasia of the limb or pulmonary embolism. But also you want to return the patient to unrestricted use of the affected extremity. Also, you want to prevent the recurrence of thrombosis without the need for necessary long-term anticoagulation. And on a more longer-term scale with Paget-Schroeder, what you're aiming to hopefully achieve is prevent long-term post-phlebitic limb syndrome in these patients, because as you will recall that these patients are usually younger, active, and present to you at a much early stage in their lives.
So that all sounds like lots of long-term management, kind of preventing things that are happening way out there. What about the very initial management strategy?
So the initial management strategy with Paget-Schroeder, if you look up the guidelines, which have been pretty clear on these issues, although there's not significant amounts of literature and data on these patients. The initial management, as per the ACCP guidelines or the CHEST guidelines, is to anticoagulate them first. And this is obviously because of the risk of pulmonary embolism and propagation of thrombus, and anticoagulation in the first setting is important. The limitations of anticoagulation are that the slow recanalization of the thrombus may lead to eventual valvular damage and intravenous scarring of these patients, and which can then subsequently lead to those long-term sequelae that we've mentioned, which is why thrombolysis has been something to be considered in this area, particularly in the initial management stage. So thrombolysis has been considered superior to anticoagulation alone in minimizing valvular damage due to residual clot inside the vein. We know this from a decent amount of evidence. Systemic lysis, however, is not favored in this patient cohort, usually because of the high risk of intracranial hemorrhage. It really hasn't taken up practice as an initial management for these patients. However, something that has been gaining traction in most centers around the world is catheter-directed lysis, and this obviously offers the benefits of lysis, which is superior to anticoagulation, as we've mentioned, but also carries a lower risk of intracranial hemorrhage for these patients, which is why it's so favored in this setting.
Yeah, and that's largely based on just the dose of TPA given, right? If you give a shorter dose of TPA compared to systemic and then given over a longer period of time, though there is still some risk. At least the practice here is that we're not necessarily lysing all of these patients, but certainly the ones that are coming in that are younger with lower risk of hemorrhage and who are having any major symptoms in that arm. What about the optimal timing of lysis? Does it need to be done immediately?
The optimal timing for lysis, it generally is referred to as the earlier the better. And the timing for catheter-directed lysis in patients with venous thoracic outlet syndrome, we say usually is in the first 14 days of onset of thrombosis. So these patients might not necessarily present to you very acutely. They can present a day or 2 days after developing the thrombus. When you look at the literature and the results of the largely retrospective series, 14 days has the best window of results. So excellent results have been reported following CDT or catheter-directed lysis if the lysis is initiated before 14 days.
After lysis, that's clearly not the last step, as we've already talked about rib resection and stuff. So what happens after that?
Yeah, so you remember that one of the goals that we mentioned was not only clearing the thrombus and getting them back to their function, but also to prevent further events and further thrombosis. And this is where the surgical decompression becomes important. So after the initial management, patients are generally divided into two groups. The first group is your unsuccessful patient who hasn't recanalized or hasn't had successful recanalization of the vein or successful thrombolysis. And persistent stenosis or signs of extrinsic compression, which, as you mentioned earlier, with venography can be elicited, has generally been perceived as a significant risk of recurrent thrombosis. So because we're doing catheter-directed lysis, this offers also a diagnostic opportunity to identify persistent stenosis or extrinsic compression. And then for those patients, surgery for VTOS remains to be mainly rib resection and decompression of the subclavian vein with or without venolysis and patchplasty, which can be done either surgically with a vein patch or with endovenous measures such as mechanico-thrombolysis or even angioplasty and stenting.
Sure, good old-fashioned balloon angioplasty, sometimes maybe with a cutting balloon or other things to help minimize that scarring. And what about some of the controversies around venous TOS?
Yeah, so there is a lack of consensus around the necessity of surgical rib resection. There's also a lack of consensus around the timing and also the requirement of further patchplasty or endovenous intervention. However, the options post-recanalization are largely broken up into two types. One, you can defer surgical decompression for 1 to 3 months after thrombolysis to allow for healing of the venous endothelium and resolution of the acute inflammatory process, or decompression during the same admission as the thrombolysis, with the main benefit being to reduce the risk of reocclusion. And usually people fall within one of these two camps of thought.
And then just into the literature, there's some landmark papers regarding venous TOS. Can you go ahead and go through a couple of those for us?
Yeah, so I'll mention two papers which I've chosen, which sort of are big series that sort of highlight the important factors. First one is Lugo J. et al., and the title is Acute Paget-Schroeder Syndrome. Does the first rib routinely need to be removed after thrombolysis? And this was published in 2015 in the Annals of Vascular Surgery. So they did a systematic literature review, and they divided quite a large number of patients, over 500 patients, into three main groups. The first group was first rib resection, which had about 400 patients in it. Then the second group was first rib resection and endovenous venoplasty, and that was about 68 patients. And then no further intervention after thrombolysis, which had 168 patients. So what they described was that there was significant symptom relief after initial follow-up with the first rib resection and endovenous venoplasty. What they found was that symptom relief after initial follow-up was more likely in the FRR, which is first rib resection and endovenous venoplasty group, compared to no ribs being removed, and that was significantly different. And their results also showed a superior patency with first rib resection and plasty and first rib resection alone compared to anticoagulation alone, which sort of fits in with what we've been talking about. And their conclusion was that patients are more likely to experience greater long-term results with first rib resection compared to no first rib resection when you look at their long-term outcomes. And whether or not you perform endovenous venoplasty is another issue, but overall, decompression is important long-term at least. And then the second paper I mentioned just to highlight, or which gives a good idea on this topic, is Sajid MS et al., which is titled Upper Limb Vein Thrombosis, a literature review to streamline the protocol for management, which was published in Acta Hematology in 2007. And this was a comprehensive review identifying the key papers on this topic, and it allows for sort of a clear view of the best management strategy.
Yeah, that's great. There's also a paper by Julie Fleischlag, who we recently interviewed. It's published in Diagnostics in 2018 regarding the care of patients with TOS. It's like a one-page review, but it goes through kind of the key publications that have been guiding her practice and many others' practice on patients with TOS. Let's move on to arterial thoracic outlet syndrome.
So with arterial thoracic outlet syndrome, when it comes to the presentation, so the most common type of presentation is hand ischemia due to arterial compression or microembolization. Another way in which these patients could present is with arm claudication or exertional pain if there's significant arterial compression. They can have unilateral Raynaud's phenomena, which is quite unusual, which is when you should think about arterial TOS as part of your differential. Subclavian arterial aneurysmal disease and pulsatile supraclavicular masses can also alert you to the possibility of arterial TOS. And rarely, in some patients, if they have significant degenerative disease process from this compression, they can have retrograde embolization into the vertebral artery, causing neurological symptoms. Thankfully, that's quite rare. The other thing to mention about clinical examination is that when you examine these patients, always look out for an audible bruit or a palpable thrill of the supraclavicular fossa. Be sure to examine for a pulsatile mass, and always look at the distal hands to exclude any distal ischemic lesions, particularly in the nail beds like splinter hemorrhages. And finally, we did mention one provocative test, which is Addison's test, which can also be helpful in diagnosing arterial TOS.
Great. And you mentioned actually Raynaud's within that last little segment, but what are some of the other things we need to make sure to rule out before we get excited about taking a patient to the operating room for arterial TOS?
So the differential for arterial thoracic outlet syndrome is the same really for upper limb ischemia. So always rule out trauma, as we mentioned earlier, or a history of trauma or a history of malunion of anything in that area. Primary and secondary Raynaud's phenomena is obviously on the top there, as you mentioned. Small vessel vasculitis can also mirror this syndrome. Connective tissue disorders, thromboangiitis obliterans, any arterial embolization from a proximal source. You mentioned earlier getting a thoracic CTA to look at a central source of embolization is also important. And also radiation arteritis can also cause this. Obviously, the more common atherosclerotic or dissection, aortic dissection can also mirror or mimic upper limb ischemia. So just always remember that common things are common, and with arterial ischemia in the upper limb, just make sure you've ruled out the more common things before you think about or confirm arterial thoracic outlet syndrome.
And on the common things are common theme, arterial TOS is the least common of those, and it is usually associated with some other uncommon things. So what are some of those more uncommon causes, or I guess common causes of arterial TOS, but are they uncommon on their own?
There are different causes of the anatomical abnormalities that can cause arterial TOS, and we alluded to this a little bit earlier. But the most common is a cervical rib. So cervical rib accounts for 60% of arterial TOS. But the more uncommons are an anomalous first rib, which is about 18%, or a fibrocartilaginous band, which accounts for about 15%. And clavicular fractures, we mentioned, exclude trauma in the history. can also be a rare cause, and an enlarged C7 transverse process, although very rare, has been described also to cause arterial thoracic outlet syndrome.
And then remind us again what the Shear staging system for arterial TOS is.
So the Shear staging has been described to highlight the varying clinical stages of arterial TOS, and it does also help identify which patients need more urgent surgery versus those patients who can be managed conservatively, at least in the initial setting. So the Shear stage is based into 4 stages, or stage 0, 1, 2, and 3. And stage 0 is the asymptomatic stage. Stage 1 is stenosis of the subclavian artery with minor post-stenotic dilatation with no intimal disruption. Stage 2 is subclavian artery aneurysm with intimal damage and mural thrombus. And stage 3 is distal embolization from the subclavian artery disease. Now, these stages, as I said earlier, don't only highlight the progression of the disease, but generally, stage 0 is considered safe to observe and survey with repeated imaging if necessary. When you get to stage 1, is when you start to be concerned about possible risk of embolization and upper limb ischemia. Remember, the stakes are very high in these patients. They're young, they're functional, and we're talking about their upper limbs, which is a huge part of their life. So we want to prevent any risk of upper limb ischemia, which is why stage 2 and stage 3 are usually considered indications for surgical management.
Which makes perfect sense. You need to go in and repair the artery. What about some of the demographics of neurogenic TOS? Moving on.
So the demographics of NTOS is largely a clinical diagnosis with symptoms and signs pertaining to nerve compression, most commonly in the lower trunk of the brachial plexus. And that makes sense because it's the lower trunk that sort of skirts over that first rib in that area. And is prone to compressive pathology. So it's more common in females than males. 70% of these patients are female in the described literature. The ages, as you mentioned earlier, early 20s all the way up to the mid 40s, where patients can present with NTOS. And it's usually because they present very late before they've actually been diagnosed with NTOS. They usually have symptoms and been thoroughly investigated over years before they've finally been given a diagnosis of NTOS. Occupational exposure is another important one. Sometimes patients won't elicit these symptoms until they've fully been pushed to the limits of what they can do with their upper limbs. And then finally, a history of trauma is quite common in these patients, particularly if they've had trauma in the past, which now has developed scarring and compression of the nervous structures in that area.
Yeah, these patients, unfortunately, by the time they've gotten to you, have often seen many other physicians and physical therapists, etc. But how do they usually present?
So the symptoms of neurogenic TOS, what you'd expect. The first sort of most common type of symptom is pain and paresthesia. So they can have numbness, they can have neck pain, headaches, weakness and swelling in the upper limb or in the shoulder region. They can have positional effects, so they can have reproducible exacerbation of symptoms while they're lying supine or while they're during overhead use of their arms, particularly lying supine with their arms over their heads. If they're sleeping with their hands underneath their heads can elicit that pain. And the common occupational or recreational activities that would be described is, for example, hanging clothes out or painting or any sport or activity that requires over the head use of the arms, such as tennis or most racket sports. These patients can develop positional effects. The other type of presentation these patients can have is actual weakness or muscle atrophy. And these are quite advanced signs in the disease process. But some patients you'll find, particularly if they have congenital anomalies that have caused significant compression of the nerves, they can have hypothenar atrophy and they can have drop off in their athletic performance over time. And they can have the inability even to carry out activities of daily living if it's very severe.
All this sounds like a neurology problem. What's the role of a vascular surgeon in treating this?
Yeah, so you're absolutely right. Most of these patients do get seen by a neurologist, and the times in which they start being referred to a vascular surgeon is usually if there's a mixed clinical picture. For example, if they have VTOS or arterial TOS associated with their NTOS, but also because a lot of this surgery is still performed by vascular surgeons, they will be referred by neurologists to us. So often these patients have already seen not only neurologists, but physiotherapists and sometimes pain specialists. And they've performed multiple investigations and tried multiple therapeutic options, which are less invasive. But then always remember to exclude those other causes, seek alternate opinions, and trial a period of physiotherapy and non-operative management first, because as we mentioned earlier, the stakes are quite high in these patients and sometimes surgery can make things worse. So it's always important to be selective in patients who require surgery. Surgery with rib resection often is accomplished, as we mentioned earlier, with transaxillary or supraclavicular approaches for these patients, particularly if a scalenectomy or cervical rib resection is necessary.
Yeah, intuition tells us that a supraclavicular approach might be best for neurolysis, etc., but the data suggests that transaxillary actually does pretty well for these patients as long as they're appropriately screened for it at the beginning and a diagnosis is really pretty sound. I think the most important part that you mentioned about all this is that this is kind of a multidisciplinary approach to these type of patients, and we're just one small part that then get the privilege of helping take care of the final problem. Nidal, that's been an excellent review on thoracic outlet syndrome. Thank you so much for all the work you put into this.
Thanks a lot, Matt. No, it's been great, and hopefully we get to do quite a few more in the future. It's been a really good program for myself, and I know a lot of the Australian trainees do find this podcast very useful.
We're very happy to hear that. If you're in Australia or the United States or anywhere else out there, and you're interested in helping us create a library of these VSITE and board review podcasts to go along with Audible Bleeding, we would love to have you take part in this. Go ahead and give me an email at audible.bleeding.podcast@gmail.com, and we'll get you involved. Once again, Nidal, thank you very much.
Thank you, Matt.
Our team is committed to providing free, high-quality, unbiased content to our listeners. We currently do not take any funding from industry sponsors or advertising, and we hope to keep it that way. So if you want to help us keep bringing you great content, go to audiblebleeding.com/support and find out how. We'll put a link in our show notes.